Hello, my name is Dr. Cheryl Burdette, and I am the clinical director for Origins Incubator. And in this week's clinical group where we come together and we brainstorm, we talked about some of the limitations in terms of diagnosing Lyme disease. And a lot of getting started in integrative care is really understanding some of the different laboratory markers that are out there, different ways of approaching things. And so in the case of Lyme disease, that is immediately obvious to any of us who began to get started in this area. So we know that, for example, the typical way that Lyme is tested for is based on a CDC criteria, but that criteria, according to the CDC's website, was never intended to be used for clinical diagnosis. It was a test designed more for epidemiological purposes, to survey an area and get an idea of percent population, but for a particular strain of Lyme disease. So we know there are multiple strains of Lyme, plus, of course, co-infections. And so when we're only looking at such a small part of the puzzle, those tests can often be negative even when the person has Lyme disease. So it's a two-tiered test, and it starts with an ELISA, looking for antibodies to Lyme, and then based on that level, we'll go on to then do Western blot, looking for certain structures of the coat of the bug to identify what is there. And so one inherent problem is that if somebody is more chronic, one of the things that Lyme disease does is it suppresses the immune system. So if the way we're trying to test it is by looking at an immune reaction, a titer, it can be suppressed, which is why the Lyme condition has become chronic in the first place. Another big problem is that the confirmatory data is not great when we look at that two-tiered testing system. For example, there were studies out of Harvard that used more sophisticated DNA analysis, and they say from the blood you could see DNA of part of the spirochete. So also, in addition to that, the inclusion criteria is that you knew that you had been bitten by a tick and that you'd had a symptom consistent with Lyme disease. So DNA fragment in the blood, symptom, known encounter. Okay, so when they look to see, would you also be positive by that two-tiered system that is used more conventionally, what they saw was that only about half the time was that the case. Other data has shown even worse outcomes than that. Another study that was in the Journal of Microbiology, also looking at more sophisticated ways of detection, now said, how well does it correlate? And what they found was that even only 1 out of 100 was correlative. And so and there are multiple studies that saw discrepancies, saw less, various sensitivities in terms of what ELISA was used, not a lot of consistency. And then, so you have laboratories that have specialized in these methodologies that have worked to make even ELISA components more sensitive, or in terms of Western blot, are looking at more bands, which means you are picking up more species in terms of Lyme disease. Also, using a more inclusive criteria. But for sure, when we are making this diagnosis, what we should really take away is that testing is problematic. Better testing is less problematic, but still not perfect. And ultimately, Lyme is a clinical diagnosis. And so using, for example, a Horowitz symptom questionnaire to know what kind of testing we should do, where it should be directed next, can be quite helpful. And always trusting your clinical judgment, because that's what's going to serve the patient the best. If a test seems off to you, that is worth investigating, because this is particularly an area where testing is not hugely fulfilling and is probably not going to, it's necessary, but is certainly going to require some interpretation, which is why people are working with us in the first place.